Hello, I'm Isabella Grumbach, the Vice Chair for this meeting. I'm at the University of Oklahoma, and I am so pleased to be here with Dr. Peter Libby, who is joining me. He's the Mellon-Ward Professor at Harvard Medical School and a cardiologist at Brigham and Women's Hospital in Boston. We are here to give you an update on this morning's first plenary session entitled Hot Topics in Cardiovascular Medicine. And Dr. Libby gave us a really comprehensive and absolutely amazing summary of our understanding of atherosclerosis and inflammation, a topic which in 2026 is on many cardiologists' mind and I believe by now well established. Dr. Libby started out by introducing us to the concepts of the past, looking at atherosclerosis as a lipid-driven disease and one driven by traditional risk factors. And we talked about how CANTOS has really changed our understanding of atherosclerosis. Dr. Libby, in CANTOS, we learned that IL-1 beta is an actionable target in atherosclerosis, and you discussed the next steps that you see on the horizon, colchicine, anti-IL-6 agents. Where are we going, and what do we need to look out for?
Yes, well, the CANTOS trial really was a win for the entire community because we silenced a lot of skeptics who thought that inflammation was hot air. And so the 15% drop in events that we saw in the pre-specified primary endpoint, which was a hard cardiovascular endpoint, really that sort of settled a lot of the controversy. And we powered CANTOS for hard endpoints because we knew this was going to be controversial. So CANTOS was a great demonstration of principle. Wonderful that we had worldwide team and support to do the trial. But we did see a signal for infection. Now, you take 10,000 people with a median exposure of 3.7 years to see an infection signal that was statistically significant. But that means that we aren't there yet. We have plenty of opportunity to optimize anti-inflammatory therapies. I like to talk about the sweet spot where we are targeting the pathways which are pathogenic, but we leave host defenses alive and well so we can fight off infections. And also we have to be concerned about tumor surveillance. For example, someone after the talk asked me about why didn't you use an anti-TNF? Well, it's because there's a signal for lymphoma with anti-TNF. So we also learned that not all anti-inflammatory interventions will provide cardiovascular benefit. So we learned that with the methotrexate study, and you can use a sledgehammer for inflammation with glucocorticoids, but particularly in acute coronary syndromes, that may be harmful. Really, the field is wide open, and there's a lot of shots on goal which are currently being explored.
You touched on colchicine, which is cheap, orally available, has been tested in trials, and now has become, at least in Europe, part of guideline therapy. How do you see the use of colchicine, and what are the advantages and disadvantages?
And colchicine is also the first anti-inflammatory agent to be approved for cardiovascular indications by the US FDA. And of course, we practicing cardiologists have been using colchicine for a long time for pericardial disease. And then in internal medicine, we use it for gout, which is an inflammasome-mediated disease. So we saw a striking reduction in acute gouty arthritis in CANTOS, so about 50% reduction. And colchicine is also very effective in gout, as we know. So we have familiarity. The problem is that, I did a back-of-the-envelope poll on one of my inpatient rotations with patients with cardiovascular disease hospitalized on my service at the Brigham and Women's Hospital, Mass General Brigham. And the average eGFR was 45 in my inpatient service. So bottom line is that a lot of our patients who we'd like to give colchicine to have impaired renal function. And since colchicine is very dependent on renal excretion, you have to adjust the dose or worry about getting toxicity in patients with chronic renal disease. That, and that there is no commercial sponsor that is pushing for uptake, has led to a rather feeble uptake of colchicine. I think the gastrointestinal unwanted actions of colchicine are usually superable. It's underutilized given what we learned about today. Now, the Clear Synergy study, which was a hyperacute coronary syndrome study, clouded the field a lot because it showed a null effect. But that study was conducted during COVID. And if you look in the New England Journal paper, they break down the primary endpoint by pre-COVID and during COVID. And actually pre-COVID, there was a signal for benefit. So that and a lot of other things limit the interpretability for me of this Clear Synergy trial. And I think that we have two independent trials in patients with chronic or subacute coronary disease, the Colcott and the LUDOCO-2 trials, really give me confidence that we probably should use colchicine more.
From just a practical standpoint, would you advise that we cardiologists, when we're seeing a patient whose LDL is whose LDL cholesterol is well controlled, should we consider measuring a high sensitivity CRP and take action, try colchicine?
You can't treat what you don't measure, as my buddy Paul Ricker quips.
Yeah.
And the latest JACC statement, for Journal of the American College of Cardiology statement, really suggests, and George Mensa was the first author, suggests that we should be doing universal measurement of not only of LDL, but of Lp(a) and CRP measured with a high sensitivity assay, because we have abundant evidence that a lot of people today with effective lipid lowering are still having events, at least over the time span of the availability of statins, and that a lot of recurrent events are in those who have acceptable concentrations of LDL, but residual inflammation. So we hope that by attacking that residual inflammation, we can really make inroads against the residual risk, even in our patients with well-controlled LDL, with the wonderful tools that we have available today. And I might say that support from the AHA was fundamental in actually doing the science underneath the successive lipid-lowering therapies, successive waves of even more potent and effective lipid-lowering agents.
There were some questions from the audience about LP little a and where you see the future going. Would you comment for the
Sure.
the
So
audience
if you
outside?
look for Lp(a),
Yeah.
you'll find it.
Yeah.
I measure it in everyone now, and I'm sometimes surprised. And certainly in patients with premature coronary artery disease or familial story of premature coronary artery disease, Lp(a) is there if you look for it. So what do we do about it? Well, today we control all traditional risk factors and we lower the LDL as far as we can get it down. I actually believe in as low as reasonably achievable. I don't go with the guideline cutoffs that have never actually been tested in clinical trials. I'm very aggressive. I am an LDL hawk, as particularly in patients who have other risk factors such as high Lp(a). And one of the reasons to do it today is for intensification of that individual proband's risk with traditional risk factor control, but also for cascade screening. Lp(a) is very strongly genetically inherited, and so I have a conversation with my patients about talking to their siblings, talking to their children, their offspring, about getting tested, and why. I've been in debates about this with big people in Europe, for example, where we shouldn't test for Lp(a) universally because we can't do anything about it, but we can. We can do intensive preventive cardiology, which is what I do in my practice. And also we can do cascade screening to identify people who may be younger and who could modify their risk factors and lifestyle to try to mitigate a risk. But help is on the way. This is the part of the talk that I give to my patients. I say, help is on the way. We have the Horizon trial with pelacarsen, which is a antisense oligonucleotide, and we'll have those results. Now we're speaking in 2026, and we will have results showing whether that particular pathway to lowering Lp(a) can yield clinical benefit. And close on the heels of the Horizon is the Oceana study, or Oceana study, that's led by my colleague, Michelle O'Donoghue, and that's using an siRNA, a small interfering RNA, which can be given at longer intervals. So we're going to have a couple of studies that will tell us whether or not in secondary prevention we can lower events by controlling Lp(a). And I tell you that I have in my practice, I have kindreds with kids who are at high risk because of Lp(a). While I was sitting in the auditorium this morning, I got an email from one of my patients who has high Lp(a), and I will have a shared decision-making conversation with them if the safety and efficacy comes out positive in these secondary prevention trials, even in people who've not yet had a myocardial infarction. It will not be in an FDA label, but the label is not a law. And I'm really concerned about a lot of my patients who have high Lp(a), despite pristine lifestyles, and who've been struck or who have family members who've been struck at a young age. The American Heart Association, if you just look under the cover, the American Heart Association has supported a lot of the fundamental research, which has led to these clinical advances. So God bless the AHA for investing in basic science.
Another important concept that you discussed this morning is clonal hematopoiesis. And really, this has become a very interesting, very well-studied topic now, in which we understand that there's this quite a widespread risk factor which can be intervened on. So, for example, in CANTOS, there I believe is a signal that this can be influenced by treatment.
Yeah.
Where do you see the next steps when it comes to understanding the interaction between the bone marrow and atherosclerosis and inflammation, and what should we look out for?
So it is true that in a secondary analysis that was not pre-specified in CANTOS, we showed a better preventive effect of canakinumab, the anti-IL-1 beta antibody, particularly in TET2 clonal hematopoiesis. So clonal hematopoiesis, very common as we age, and it involves somatic, acquired mutations, not what you inherit from mom or dad, that give rise to a expansion benefit for this clone. And you can just sample peripheral blood, and with a couple of different kinds of sequencing techniques, you can define people who have this clonal hematopoiesis. We call it clonal hematopoiesis of indeterminate potential because most people who have it will never know it. It certainly elevates by more than tenfold your risk of developing leukemia, but the rate of actually developing leukemia is 1%, 0.5% a year. But what we've learned is that there's an enormous increase in cardiovascular risk with certain of these mutations. So that opens the whole new perspective into risk stratification, understanding one of the aspects of the increased cardiovascular risk with aging. It unites, I love the biology because I'm having to learn, stretch my brain to encompass oncology now, cancer genes, cardiovascular disease, and aging, three of my favorite topics. So I think it's a new frontier. It's going to be very challenging, though, to actually act on it. I established a CHIP clinic, I think maybe the first one, in 2019 with Amy Lynn, who was then our fellow. I've been through 4 successive fellows. I'm very proud of them because they now all have faculty jobs. And I'm angling for my current fellow to get a faculty job. And so what do we do in a CHIP clinic? Well, I practice just preventive cardiology raised to a power. And I do have a shared decision-making conversation with patients with TET2 CHIP about vitamin C, or ascorbic acid, which is a cofactor for that enzyme, which is involved in methyl transfer. So it probably has an epigenetic mechanism of action. But what I am going to try to organize is an international consortium to work on clinical trials, because no one center is going to have enough of the patients with specific mutations or a particular swath of variant allele fractions. I have one patient who has 3 separate mutations in TET2. The highest variant allele fraction is 43%. So I'm really worried about that patient. But we really need to have an international consortium to try to solve some of the problems, because each CHIP mutation, it turns out, is its own risk mechanism and factor. And so although there's a number of separate genes that can be mutated to give rise to clonal hematopoiesis, we're probably going to have to separate our clinical trials, and we're also going to have to worry about the variant allele fraction. Is someone with ENMT3A chip who has a variant allele fraction of 2.5, do they need to have any special attention? And that patient with a 43% TET2 with 2 other TET2 mutations, I'm really worried about how do we design a clinical trial that can cover the entire spectrum of CHIP. I need help with that, and I hope that international outreach and cooperation will help us to really do some trials to try and target clonal hematopoiesis. Some of those mutations are definitely involved in inflammatory signaling, such as TET2, AXL1, and rarer but very dangerous is JAK2 mutations.
We touched on CHIP, the next steps after CANTOS. We spoke about LP(a). There are few people who have worked so intensively in this field in the last decades and really changed our perspective on atherosclerosis. If you had a crystal ball, where will we be in 10 years? Where do you see the next potential targets?
I think that we will converge on the sweet spot where we're able to target the pathways which are pathogenic for cardiovascular disease and have a minimal effect on host defenses and tumor surveillance. So it's going to take many shots on goal, but hey, I've got a lot of energy and I want to see these different anti-inflammatory strategies, which are quite wide-ranging, to be tested. So for the Centennial Collection of ATBB, I was invited to write a piece about exactly what you're asking about. And I'm a great believer in international collaboration. So I invited Hafid Ifela from Saint-Antoine in Paris and the PARC, the Paris Atherosclerosis Research Center, to join me. And so if you look in that Centennial Collection from a few years ago, might need a little update, but I outline with Hafid some of the ways in which we can take those shots on goal to try and find that sweet spot.
Thank you very much.
It's a pleasure. It's a great privilege to have given the keynote here. And it's particularly wonderful because this is AHA sponsored, and AHA has done so much for the community and for public health. And the other thing that's really good about this meeting is the young people and their energy. I did a session on career advice this morning, and 7 a.m., and there's the future. And this meeting really gives them a platform.
I think this has been a long-standing emphasis of this meeting to really involve our young generation. So thank you for inspiring us to think broadly about the future.
It's a privilege to be here with you, and thank you.